So y'all help me when y'all can see things, in case I miss it. We've also got some duplication on here that people have noticed, that we'll try and take off the more generic one and put the more specific one on here. Okay, let's start with fluid volume overload. Well, first off, which one was the easiest?
Fluid volume overload.
Yeah, fluid volume overload is pretty much the easiest. Which one do you think was the hardest?
The calcium.
Yeah, the calcium and phosphorus. It's not as like, ding, 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 problems. Yeah, this is the one that you're gonna die from. So, we always know in nursing school, there's t-shirts made for a reason. When in doubt, pick potassium. Okay, let's start with fluid volume overload. Let's put all of our vital signs together. So, I'm gonna move some things around just so I can put things together. So, vital signs, why is the heart rate elevated?
You don't have enough volume to overcompensating for the low blood pressure.
So, nope, I've got too much volume, there's too much going on, my heart's being worked really, really hard. So what's my blood pressure doing? Elevated, there it is. High blood pressure, what's my respiratory rate doing? Is that up there?
Yes, shortness of breath.
Woo, we didn't put what my respiratory rate is though. Are you gonna have a high respiratory rate or a low respiratory rate? Or a normal respiratory rate?
Hi.
You're gonna have a high respiratory rate. Why am I gonna have a high respiratory rate? Because you're short of breath and your heart rate's beating really fast. Alright, high respiratory rate. I see O2 stats on here. Where'd it go? Low O2 stat. Is my temperature gonna be affected? My body temperature is not gonna be affected. What's my external, what am I gonna feel like?
Cool.
You're gonna feel cold but have a normal body temperature, so we're not gonna put temp up there. Okay, let's do all of the pulmonary issues now together. So you already said shortness of breath, so we'll put shortness of breath right there. Orthopnea, what does the word orthopnea mean? I gotta sit up to breathe, I can't lay down to breathe, so I gotta sit up. So orthopnea, I may have some cyanosis because of the low O2 stat. I may have some crackles. What does crackles tell me?
The fluids.
Fluid in the lungs, free fluid in the lungs, floating around and everything. Can you suction crackles? Sure can't, it won't come out. Let's see, what else respiratory is on here? Thank you, frothy sputum. What else about this sputum? It's frothy, but what else? Pink or blood tinge? Alright. Pink or blood tinge, because we've got blood accumulating too much in our lungs. So we're gonna get pink frothy sputum. Is that all my respiratory stuff? Breathing fast, low O2 stat, pink frothy sputum. Cough. Wet cough, dry cough. Wet. Marker stuff. Wet cough. Okey doke. I'm going to take low grade fever off because just having fluid volume overload or deficit is not going to cause a fever. Fever's going to be caused by something else. Okay. Let's look at our body. We got weight gain, which also is going to include third spacing, hitting edema. What else with our body? Ascites. How can you tell ascites from distension versus just someone that's overweight? How do you determine if it's ascites? I'm just looking at a belly. If I see somebody with a big belly, how do I know it's a beer belly, an ascites belly, or
It's
a
hard.
belly because they ain't pooped in 2 weeks? Well, assess it. This is the one time we're gonna do that. Y'all remember that test called percussion? That nobody ever does? Yeah, this is the only time you're gonna use it. On a belly, you can percuss the belly. If it is loud and high-pitched, a high-pitched sound, that timpani sound, what does that tell you? What does that tell you? It's full of air. They're distended. They have an ileus. They have a constipation issue. It's also tight like a drum, super tight when it's distended with air. Now it's trying to determine, so distension's pretty easy to tell from, you know, like an overweight abdomen or an ascites abdomen. The overweight abdomen and the ascites abdomen are a little bit more challenging to tell the difference because they're both soft, tend to be non-tender, like a distended belly tends to be very tender and it hurts. But if we just have like a beer belly or an overweight belly, we can tell the difference with that with ascites by doing our percussion as well. So we have something called the fluid wave test. Does that sound familiar to anybody? You read about a fluid wave test? All right, so if you put one hand either in the middle or on the side of the belly and you tap the other side, you will actually feel the water hit your hand. And you can see the fluid wave go across the belly. Yeah, if you try it on just an overweight belly, it just kind of stops right over here. But if it's an ascites belly and you tap it, you're gonna see it go smack your hand. Yeah, fluid wave test, like Google, YouTube, fluid wave test, and you'll see it. It's pretty cool. So I have a lot of liver patients on my unit, so a lot of times I get to show you guys one of those. Okay, we said ascites. Anything else body-wise? Edema, we already said edema, so let's just go hitting edema here. Extremities are gonna be colder. Why are they gonna be colder? If I have a whole bunch of fluid between my blood and my skin, what's more, blood or excess fluid?
Blood.
The blood is. So the excess fluid is gonna make my touch temperature feel colder because it's cold. I saw weeping on here. Where did that go? There it is. Weeping. Weeping, what does that mean? Yeah. How high do we go up on edema? What's our scale?
4.
All right, so we can go up to 4+. When you go up to 4+, that means your skin can't stretch anymore, and then all the fluid starts weeping out of your body because I can't stretch any further. So we've got 4+ pitting edema, then we go to weeping fluid out of your extremities. Anybody seen anybody weeping?
Does that just look like sweat?
It looks a little yellowy. It's got a yellowy color to it, so a lot of times you might think your patient's urinated in the bed, but it's not enough fluid and it doesn't smell like urine. It is yellow. It's just they're weeping.
Mm-hmm.
JVD, I'm gonna take skin flush off of here because it tends to be a little cold, tends to be a little pale or cyanotic as opposed to flushed. Alright, let's do neuro. We've got AMS, they can have altered mental status, they're gonna be tired, they can have cerebral edema, so I like all those together for neuro. Bounding pulse, I agree with. What else? Yeah, bounding pulse, that's good. Let's do labs. We've got low sodium. Why do we have low sodium? Because it's diluted out. We also have low H&H wine because it's also diluted out. All this BUN, all that kind of stuff may or may not be true depending on the cause. So I'm gonna take this one off just because it's gonna depend on the cause. Because in our case for the kidneys, the BUN's actually gonna be really elevated. So it depends on the cause. Low urine output, we'll leave that. I'm gonna take hypokalemia off just because most times when we have patients who are in fluid volume overload due to kidney failure, they don't have hypokalemia, they have hyperkalemia. So we'll take this one off. I'm gonna put seizures back up here just because it possibly may be due to the hyponatremia. So I'm gonna let you have seizures back, but I'm gonna tag it to the hyponatremia. So not necessarily from the fluid volume overload, but from the low sodium level. So we'll put that back up. Okay, how we feel about fluid volume overload? Fair? I'm gonna add one more word that I just thought of. What's that word for full body edema? General, there's a, golly, that looks terrible. Can you rewrite that? Hang on.
For the Anasarca or something?
There you go. So, generalized whole body edema, we have a word for that, and it's called anasarca. So, when we're done, y'all can take pictures with your phone, and we'll put it up on Canvas too. All right, let's start putting together some of these these interventions. All righty, so let's see. I'm gonna take off assess for different things. So assess for JVD, I'm telling you already got it over here. So I'm taking off assess for JVD. What else? What other assessment can I take off? Monitor electrolytes. We were talking about our electrolytes already. Assess for edema. I'm gonna take that one off because we're already assessing.
God dang.
I know. Well, we're already saying it's.
We didn't see that.
I know. That's fine. That's fine. Okay. Okay, so we're gonna say, monitor, I'm gonna leave that one, okay. We're gonna say fluid restriction, so we're gonna start with our fluids, so restrict fluid.
We got one.
We're gonna restrict sodium, because where sodium goes, water follows, so we're just gonna not add sodium to it. Let's see, there's always this, the hypertonic fluids versus the fluid restriction. That's always a debate. Did y'all go back and forth with this one? Yeah. So, we do not fix the salt. We fix the water. If we fix the water, the salt will normalize itself. So we don't fix the salt in this situation if we're fluid volume overloaded because of kidney failure. Because of heart failure, we're gonna do heart failure and perfusion too. This is more like your water intoxication people or like your drug-induced hyponatremia type situation. So we're gonna go with just fluid restriction. Diuretics, what kind of diuretics? Put that one down because that's two different diuretics in one. We'll just have the one. I don't just have the one, because y'all put two of them at the same time. What is our gold standard? Number one, diuretic for fluid volume overload. Lasix, which is a loop diuretic. Loop diuretic. So furosemide, butanamide, all of those ones that end in -. So loop diuretics are our go-to. If we're in an acute situation, we do loop diuretics. Spiralidactone, that is your more chronic. We take it every day to treat fluid volume overload, to prevent fluid volume overload. If you are in a fluid volume overload crisis, your body's gonna take that spiralidactone and go, you're cute. Does not help with an acute situation. We want a loop. Elevate head of bed, turn coffee free. Is an incentive barometer gonna help you get fluid out of your body?
Mm-mm.
Maybe. It's not. It's not. I like daily weights and strict I's and O's. I like monitor for fluid volume deficit because we're given Lasix. We don't want to swing the pendulum the opposite direction. So we like that. I like neurochecks and seizures because we do have a low sodium level, so we're at high risk of seizures. I like that. Elevate legs, elevate head of the bed. Yeah, we do want our fluid to get to our heart so that it can pump correctly. I want bottles, I want cardiac. Yep, we're assessing. We know we're assessing. But I do want cardiac telemetry because that's going to be, I need to be looking out for what my heart rhythm is. Assess for skin breakdown. And here, I like this one because they can have a lot of skin breakdown because of that weeping type situation. So I like that one. Keep them turned. Yep. Okay, let's say our loop diuretics didn't work.
That's all you say.
How long do you do the diuretics until you determine they're disabled?
If they're in trouble, are you dying or are you not dying? If you're continuing to die, we need to do this today. I'll put dialysis down at the bottom, in the bottom corner, because it is a last resort. Dialysis is a whole process. We gotta bring in lots of folks, we gotta bring in trained people, we gotta get access. It's a lot of work. And we'll put it down at the bottom because we want to try our diuretics first. I'm gonna go ahead and add to this another type of diuretic that can help our dialysis work better. So there's another type of diuretic that will help dialysis work better. Everybody know it? I know you girls. Mannitol, which is a osmotic diuretic. It helps my dialysis work better. Have some mannitol. So let's talk about it. All right, everybody listen. Shake that if you can't hear it. Shake it up when you get it. This is mannitol at room temperature. What do you know about that mannitol? It's crystallized. So how am I going to give mannitol? There's probably about 10 mLs left in that bottle.
Roll it between the
All right. So if it crystallizes at room temperature, do I want it warm or cool? I want to warm it up. How am I going to warm up that bottle? That's not going to be good enough. Y'all can try it like Road Dog wants to. See if it'll warm water. Warm water. Don't cover the top. So just get you a little emesis basin with some warm water and stick it in. So we're gonna now, y'all. This takes like months for this to happen. It's not like it's gonna happen in 2 days. It takes a while. But just if you see crystals, if you can visibly see crystals, you need to warm it back up. Okay. It can also be crystallized in a bag. Like if you've got to give a bag of mannitol, like over an hour, it can be crystallized in the bag. When you draw that up, what are you going to draw it up with? A filtered needle. Okay. If you're going to give it as an IV piggyback in a bag through some tubing, what are you going to put on your tubing?
Filter.
Filter on your tubing. Have y'all seen filters on IV tubing?
Yes.
All right, so you can just, if you haven't, you just go grab it out of the supply room. So if you're given mannitol, has to be warmed up because at room temperature it crystallizes. You have to use filters. Filter needle, filter tubing for the crystals that you can't see. Okay. What does an osmotic diuretic do? Does it really make you pee? What's it going to do?
Osmolarity.
Pull the fluid from the third space to the vasculature, so then hopefully your kidneys work and you can pee it out. So it doesn't actually make you pee. You have to have functioning kidneys for this to actually work. So if your kidneys don't work, is this going to help?
Mm-mm.
No, because it's just going to go to the vasculature and then it has nowhere to go. That's why I said it makes your dialysis
Why do they give this to
work better.
patients who have
Because
ascites? Why do they give
dialysis is
albumin?
going to filter the blood. So if I can get all the excess fluid
Should I ask her that question?
from the third space into the blood, my dialysis will be much more effective.
Why don't they give it to patients with ascites? Because I know they give albumin to people with ascites. Why just they don't give mannitol?
Alright. That's my next one.
Okay.
We could give mannitol, or we could give
Albumin.
albumin. Only to make dialysis work better. Because we're trying to, it's an osmotic, we're trying to pull it into the vasculature. So I'm not saying we do this for fluid volume overload. I'm saying we do this to help my dialysis work better if we're doing it.
That was up there. I want to give that team credit. We took it down. I think it was orange.
Go, yep. I'll take mine off and give you the orange one back.
Sorry.
Alright, so, but I did want to just clarify, it's only for dialysis to make it work
Only for
better.
dialysis, okay.
Yeah, just for that one. Mannitol patients either respond to one or they don't. So if they try albumin and it doesn't work, they may try mannitol. Albumin tends to be the one that everybody's going with a little bit more right now in today's culture. About 5 years ago, everybody was getting mannitol like it was, going out of stock or something. So it just kind of depends. It ebbs and flows. They do the same thing. They're both going to pull fluid into the vasculature to help us get rid of it better. So those two things can help with dialysis. Yeah, feel pretty good at that. O2 is needed. We'll let you have that one back too. Because if you have low O2 sat, you can't breathe because your lungs are filled up with fluid. Let's give you some O2 so you don't get in trouble. I'm not going to give you paracentesis though. Just because my mannitol and my albumin should help pull that back in. We don't like doing paracentesis unless we absolutely have to. Like this is a very last resort. That dialysis is going to fix it. So I'm not going to give you that one. I'm going to say I've got ambulate here. And I've got PT consult here. I'm going to say activity as tolerated because if you have somebody who is in this situation, high heart rate, high blood pressure, high respiratory rate, low O2 sat, do you want that person getting up and moving? No, you probably need to sit your butt down and chill and don't get up and fall. So it kind of depends on your situation. So I like ambulate for people who are able to. But this person, if we're doing worst case scenario, they need to be on bed rest. They don't need to be getting up. So, okay, hyperkalemia. Anything else we want to add? Critique, deal with? Hyperkalemia, high potassium levels. We're going to clean this one up a whole lot. Because a lot of this stuff, let's put all of the dysrhythmias together. Wide QRS. Y'all will learn about it when we get there. PVCs goes with the wide QRS. Prolonged PR interval goes with that. The main thing for you guys, y'all have heard peak to T waves, right?
Yeah.
We're going to see what that looks like in perfusion. Peak to T waves. We've got prolonged wide QRS and we've got shortened QT interval. Those two things are opposites. We'll take that one off. Because we have a wide QRS. Sine wave, I'm not sure what that is. I don't know what it is. What does it say? Sine wave? I don't know what that means. What's the purple group? I don't know. It's obvious that y'all go down your test because I don't know what it means. So, if you were meaning U wave, no. U wave means low potassium, not high. Is that all my PCT waves? Okay, and then your heart rate can be high or low. It can be either one. So I like Tacky / Brady. So we'll take Tacky off. VTAC and VFib would be the ultimate. Like this is kind of like a progression a little bit. So we're going to start out with some wide QRS as we can get all the way down to VTAC, VFib. This is a lethal rhythm. We're going to have to resuscitate you. It's a lethal rhythm. Okay. Now the rest of it. DTRs. Anybody ever checked a DTR? Who wants to be an OB nurse in here? OB nurses? Anybody? Anybody? Nobody wants to be an OB nurse? Oh, but out of 40 people, I usually have one. I mean, let us go to clinical first.
Yeah.
You really want to.
OB nurses are the only people that check these things. Or like if you work in a neurology clinic where you have things like multiple sclerosis, Guillain-Barré, those types of diagnosis, ALS, those things. Nobody checks DTRs. We're just gonna put it right now. Let's see. Muscle cramps, sure. Seizures, not really. Seizures are more for sodium. Nausea, vomiting is usually a cause, not a result of. Let's see, diarrhea, not really, you don't have diarrhea just because you have high potassium. Limp legs, that kind of goes with DTRs.
What did we learn?
I'm not very good at it. Well, we're cleaning it up for kidneys, remember? We're cleaning it up for kidneys.
That's fair. Okay.
Like, I'm curious that y'all know the major points for a kidney failure patient rather than literally everything. Does it really drop your blood pressure significantly? It mainly affects your heart rate. So if your heart rate shoots way up through the roof, what's your blood pressure gonna do? Your blood pressure is gonna go down. So typically, I'm just gonna take that off. Colic, is this for babies? Chest pain. Just because you have high potassium level doesn't cause you chest pain. If you go into these, you can have some chest pain. High potassiums don't cause heart attacks.
But is chest pain a sign and symptom of hyperkalemia?
The dysrhythmia is. Chest pain is a sign that you do not have oxygen to your cardiac tissue. Sure. Oh, hi. Read on. Okay. Low calcium. Does a high potassium cause a low calcium? Do they have an inverse relationship?
Mm-mm. No, they're best friends.
Thank you. Does a high potassium make your vowel sounds get higher? So this one's actually pretty lean now. Alright, irritability, lethargicness, ultramental status, I'll give you that. Paralysis, muscle weakness, I'll give you that. Shortness of breath a little bit, maybe because of all this stuff. So, we cleaned that up for kidneys a lot. Alright, what are we gonna do about it? Did y'all get my other drug? Intervention? No?
I shouted it out loud. We wrote down what you put last time.
Okay. These feel more together, except for the drugs. Let's do all the drugs, or no. Let's do no salt substitute. Why no salt substitute?
High potassium.
Potassium.
What does the light blue say on hyperkalemia? Like, to the left?
High sodium. That's great.
Does high potassium make your sodium go up?
Make sure.
Looking for the. This causes what? Not what you might see along with it. What does this cause specifically? I think y'all are kind of grouping like, well, if you see this, you'll probably have this too. Grouping together. So we're looking for like symptoms of. Okay, thank you for pitching. Tell me if I missed other things.
It
Okay.
sounded aggressive, but I really could not read it. I didn't know if it was a medication.
No, I just missed it. All right, no salt substitute, correct. KXLA, do we give KXLA anymore? No, not really. It's still appropriate. Some hospitals may still have it.
Follow up, what is that?
Hang on, where's the other name for it? Sodium polycisterine. That's the same name. KXLA is either something you drink or an enema, and it binds to the potassium and excretes it through the GI system.
What is also Localma?
Localmas! You shouted it, I know you did.
Are those two different things? Are they two? Yeah.
They are two different things.
What?
I swear Bridget said KX late before
bought
coma.
KX late. Oh.
Okay.
She told us they were the same thing.
Yeah.
They bought it, and I think they're trying to completely get rid of the old formula of KX late because that was a water soluble. This is a fat soluble, or vice versa.
So
They work exactly the same.
Okay, so now they're not.
They work exactly the same.
Okay.
KXLate causes massive diarrhea. That's why we don't give it no more.
But isn't that not
Localma does not cause massive diarrhea.
Okay.
Do you still get them like 3 to 4 poops a day?
It is, well, this is more normal poops. Y'all need to know about KXLate.
Right.
I'm talking like
Yeah, that's what I'm
tell
worried
us,
about.
bottom of the bed dripping off the corner, water, poop. the head like how babies do when it just goes up their diaper. Yeah, K-Exolate, I can't remember which one. One's water soluble, one's fat soluble. I don't remember which it is. K-Exolate causes massive diarrhea. Lokelma does not. You may have given Lokelma.
Never.
You gave Lokelma? How does it come? What form?
Like a packet powder.
It's a powder form. What's the generic name for Lokelma? It's not.
Not K-Exolate.
Google it and tell me if I'm wrong.
What's the other one?
Zirconium. Sodium, zirconium, C-I-R. C-I-R. All y'all are saying all at the same time. Sodium, zirconium. Okay. Lokelma. Lokelma comes in a powder. If you ever have to give it to a person, you need to stir and shot.
Yeah, we've done that.
Stir, shot. If you leave it sitting, it separates out, and you will drink it, and all the powder's still sitting at the bottom. It's like moon sand. This stuff does not
Mix.
actually mix. So if you're going to give it to a person, stir it, and then tell them to drink it super fast. If you're putting it in a G tube, an NG tube, you're going to have to shake and then push. Okay, because it separates almost as quickly as it comes together. So it's powder form. K-Exolate comes in a liquid. It's orange. It stinks. Causes all the diarrhea. So, zirconium, moon sand, shot.
What's the one under, K-Exolate?
Sodium polycystyrene, which is the generic name of K-Exolate.
I didn't realize it.
K-Exolate's a brand name.
It sounds like a generic.
It's not. It does sound like it. Okay, fall precaution. I'm moving out of the way. Insulin with dextrose. Insulin with dextrose. I'm gonna take the pink one off just because. Give it to the purples. What kind of insulin? Regular. How? Route. IV. What route do you normally give insulin? Sub-Q, so make sure you're giving it IV. Dextrose, what kind? D50. 50% dextrose. Why do I give 50% dextrose?
Because it opened up the cells to allow the potassium to go back inside.
Alright. So the insulin and the dextrose work together to get the potassium back into the cell. If you give me, I'm a non-diabetic, if you give me 10 units of insulin IV, what's going to happen to me? I'll say I might die because I'm going to pass out from a blood sugar of 4. So you have to give me 50% sugar. So you got to give me a big old dose of sugar if you're going to give me 10 units of insulin IV. It does not matter which one you give first. You give them together. Do not give one and wait 30 minutes to give the other. You give them together, so back to back. Sodium bicarb, that's just going to help because this is an acid, monitored in. Daily weights, does hyperkalemia make you get fluid volume overloaded or deficit? No, just kind of happens. Eyes and nose, yep, I like that. Furosemide and Lasix are the same thing. I like those. That's our go-to for our diuretic. Calcium gluconate for cardiac excitability. Does calcium gluconate drop your potassium level? It does not. It calms the heart. So calcium calms. Calcium calms. So it's going to help prevent this. No potassium supplements. Already did that. Monitor. Yep. Dialysis, I'm going to put it down here because it's also a last resort. Fix this one off. Okay. We feel good about potassium one? hyperphosphatemia. So we have one word on here that kind of is an umbrella term for the group of signs and symptoms that we have with hypocalcemia. So you may know my umbrella term that covers a lot of signs and symptoms. Very good, tetany. So I'm gonna put tetany right here. And we're gonna put tetany in order of how it occurs as we see it. So like early signs and late signs of tetany, okay? So I'm gonna go ahead and take DTRs. You've already heard my spiel about DTRs, so I'm gonna take it. Not that it's wrong, it's just ain't none of y'all ever wants this. Okay, tetany. Early signs of tetany. What's that gonna be?
First question, what's tetany?
An umbrella term that describes the symptoms of hypocalcemia. That's what it is. It's a muscular term, like muscular irritation. Alright, so it's all muscle related. So what's the early signs? Okay, so not spasms. First off is going to be the tinglies. The tinglies, the paresthesias, the numbness. Did I see numbness up there? Yeah, numbness in limbs and fingers. Let's see, what else? Yeah, so we're going to start out with kind of numbness, and it's in the far extremities, like the fingertips, the toes, the lips. Start getting those numb, tingly, like paresthesias, feels like you're being stabbed with needles type feeling. That's the earliest sign of hypocalcemia. It's a very early sign. All right, if this is allowed to progress, then we start getting into the muscle spasms and muscle cramps. Muscle spasms, muscle cramps. If this is allowed to continue, then we start getting those signs that you learned about that have weird names. What is that? Chavostics and Trousseau signs. What's Chavostics sign?
The cheek.
The cheek. How do you assess it? So you got to go from the tragus of the ear, come forward to where this is where the nerve comes out, and you're going to tap it, and what happens? Yeah, their face is going to pull up. It's going to cause a spasm of the facial muscle. So they're going to have a face spasm that's going to pull up related to tapping on that nerve, because there's a nerve right there. All right. Hopefully you don't make yourself do it unless you got some low calcium. All right, Trousseau sign. What is that?
Blood pressure.
Put the blood pressure cuff on. You pump it up, and what happens to the arm? All right, they're going to have, again, all the muscles are going to spasm or cramp up, and they do this weird, like, claw thing. Yeah. So, my stupid way of helping you remember that this is for low calcium levels is that if you see somebody during your assessment and they're doing all this stuff, just remember your patient is telling you that I need calcium. Need calcium. Alright, I've had people do this before to me. It's very scary. So this does not really affect your mentation very much. So I had one lady that her calcium level was very low, and she was just like this. Just like her arms were twisted up like this, her whole face was scrunched up, and it was very scary because we knew her calcium level was so low that she was like this. Because what's the next sign? Hang on, let me find it. Laryngospasms. Because if your muscles are doing this, your larynx can also do this. And then you can't breathe. So it was terrifying for us as the rapid response team because she was already cramped up to that point. I was terrified that her airway was just going to spasm down on us as well. So it was very, very scary. So we had to address it really quickly. You can have laryngospasms. You also can have, what else? Do what? Cardiac dysrhythmias, lethal rhythms. So you can have your airway closed down, and you also can have your heart just like completely spaz out and go into a lethal rhythm. Because what does calcium do for your heart? Calms. So if you have no calcium in there, your heart's just like, I'm gonna do whatever I wanna do and freak out and can go into a lethal rhythm. So, lethal rhythms. So that's the progression of technique. We want to intervene as early as possible. So if we start seeing this, we want to intervene at this point so that they don't progress down to this point. It can cause seizures as well. I'm gonna put that in with Trousseau and Chavostick sign because it kind of can go about right there. Dysphagia kind of goes with the laryngospasms, but it's not the dangerous, scary part. Just means you can't swallow very safely because your larynx is causing you some problems. I mean, your esophagus is causing you some problems. EKG changes goes with that one. Bradycardia, not so much because it could just be anything. It could be crazy heart rhythm, so we'll take bradycardia down because it can be a lot more things than just that. Blood clotting, I know that's the right answer, but it rarely ever happens. Like, it just doesn't affect it that much. Let's see. Pruritus. Why pruritus? Why they get itchy? Y'all had confidence when you put it up there, not so much confidence when you want to tell me, do you?
We just know it's a sign, okay?
All right, they can get some of those. A lot of times this happens with my renal failure patients because they just get salts that deposit into their skin. So I'm going to leave it up there because you can have some of this, but yeah, not super. I'm going to take the coarse hair off because how do you know somebody's hair is coarse or not coarse unless you already know them and you got a baseline? How do you know somebody's hair is more coarse than that? So I'm just taking it off. Heart failure. Does low calcium levels cause heart failure? Can heart failure cause low calcium levels? Potentially. So yeah, that's more of a cause as opposed to a sign and symptom. Coma death. Well, we all can have a coma death for many things. I gave you more specific, so that's why I'm gonna take it off because I gave you more specific reasons. Let's look at the bones. Risk of fractures. Why?
Osteoporosis.
Yep, so if you have low calcium, you're gonna have decreased bone density because what's your body gonna do?
Get
It's
the
gonna pull all of that
calcium from the
calcium out of
bones.
the bones and put it into the bloodstream, which is gonna cause you bone pain, osteoporosis, brittle nails. Where's the other one? Risk of fractures. Oh my gosh, y'all, it's right there. So, risk of fractures because of the low bone density. Why do they have bone pain? All right, so if your bones, if all the calcium gets pulled out of your bones to get to your bloodstream, what do your bones do in response? They try to build themselves up with no calcium, which is a lot harder. So they're overcompensating, trying to build themselves up with no calcium. So it hurts. Your bones need calcium to be able to be strong. So if they're trying to do it without calcium, it's very painful. So bone pain due to them trying to compensate for the lack of calcium. You can be tired, altered mental status, irritable, you can have all that stuff. I'm gonna take off nausea, vomiting. It doesn't cause that, but that can be a cause of. Decreased PTH is a cause more than a sign. Decreased vitamin D is more of a cause rather than a sign because we need vitamin D, right? So a lot of causes there as opposed to signs. Diarrhea cause. Yeah. Hypotension, low calcium doesn't cause really not significant hypotension. Okay, so that one's cleaned up a bunch. All right, so hi. Let's talk about what we're gonna do about it. Neuro checks. So high calcium, low phosphorus diet. Do we got diet stuff in here? Let's put that together. Why avoid dark sodas and processed food? dark sodas is part of the color. So if you get a Coke, a Dr. Pepper, a Diet Coke, anything that has the dark color in it, a lot of that is phosphorus. If you buy anything that is shelf stable for a long period of time, so anything that's in a box like Hamburger Helper, Lipton, the taco kits, anything that's processed to be shelf stable, the chemical that is used to make it shelf stable is phosphorus. It all has phosphorus in it. So everything in the middle of the grocery store, a lot of phosphorus. Get on out to the edges of the grocery store, less phosphorus, because you want more fresh fruits, vegetables, meats, seafood, stuff like that. Is that expensive or cheap? That's expensive. For the most part, it's going to be more expensive to get those fresh vegetables, stuff like that, rather than just buying a cheap box of cheaper than the other things. So this is where we get into some trouble with our renal failure patients, because the diet that they've been on has caused them problems, and now the diet they continue to be on is still causing them problems. So we'll talk more about diet with our renal failure patients, but avoid dark sodas, avoid processed foods. Is milk good? It's high in calcium. It's also high in phosphorus. So it's kind of a null and void. It's high in both. What else is on there? I'm trying to think of other things. I'll think of stuff as it comes to me. Fall prevention. Yep. All right. Vitamin D. Why do we need vitamin D? All right, we need vitamin D to help us absorb calcium. So, UV light for vitamin D or just vitamin D supplements, those are good. Let's see, what else can we do? Calcium supplements. What's calcium? Tums. What is Tums? Acetate. Calcium acetate. So Tums are good. What is a phosphate binder? Alright, Selvamir is a phosphate binder. So how do phosphate binders work? Works in the GI system. So everything you eat, you take a phosphorus binder, binds to the phosphorus, and you don't absorb it. It just goes right through your system. So when should you take your phosphorus binder? With your meals. So a typical order for Selvamir or Foslo or Renagel, like there's several different kinds. A typical order is going to be like 2,000 milligrams in divided doses with meals. So if you eat 3 meals a day, you're going to take 2,000 milligrams, you're going to divide it up into 3 times because you eat 3 meals a day. If you only eat 2 meals a day, like if you're a non-breakfast person and you only eat 2 meals a day, you're going to take it with those 2 meals. If you like to have more meals, like if you have, second breakfast and lunch and dinner, if you eat 4 times a day, you're going to divide it up into those 4 times a day. So typically in the hospital, we just do the 3 times a day because that's when we serve breakfast, lunch, and dinner. So in the hospital, we usually just kind of keep it strict like that. But if we send people home on it, we're going to tell them, divide it out on how many meals you eat. Or we're going to ask them that, and we're going to go ahead and divide it for them and tell them how much to take. The whole point is you got to take it when you eat so that you can prevent your body from absorbing that phosphorus while you eat. Magnesium doesn't really help with calcium and phosphorus. What does magnesium help bring up? Potassium. This is your go-to if you have hypocalcemia. If you have low potassium levels, that's where you really need this. So I'm going to take it off because it doesn't really help with my calcium levels that much. It helps with my potassium. IV bolus.
We had it attached to med.
Which one?
I think it was calcium gluconate.
Yeah.
I don't even see calcium gluconate. Where'd it go?
Calcium gluconate,
It was
Abigola.
somewhere.
Oh, right there. I'll put calcium gluconate up here. Alright, let's talk about calcium gluconate, because that's an IV version. Alright, calcium carbonate, how do we take that? PO. Tums is PO. Calcium gluconate is IV. How do I get the crappy marker again? Alright, let's talk about calcium gluconate IV. That is a vesicant. If I say the word vesicant to you, what does that mean? It is going to tear up your vasculature when you infuse it. So if anything is a vesicant, we have some precautions that we have to take to give these safely. You will have a vesicant question on every test that I give you because you will have a vesicant medication, a new one for every single test that I give you. So for the renal test, your vesicant is going to be calcium gluconate. So, or calcium chloride. Any calcium you give IV is going to be a vesicant. All right, so what are some of my things I can do to protect my patient from injury when I'm giving a vesicant? So filters don't help me. That's what I need for mannitol. All right, I'm just going to make sure it goes in really, really slow. So if I'm doing an IV push, this is like a 5-minute, 10-minute IV push. It's going to be really, really slow. I may even need to put it in an IV bag and run it over 30 minutes, an hour, 2 hours, depending on the dose. So I'm going to give it very slowly. What else? All right, dilute it. Make sure it's very diluted. We don't give it super concentrated. What else?
You do cold compress. I know sometimes it depends, like you do warm or cold.
That's really not going to help prevent things. That's more of a problem happens. So it's just diluting it. Yeah, so if I want to like run me a normal saline line and then Y-side it in, that dilutes it out. So this part is diluting it. What else?
Yeah, flush it.
Make sure we do a good flush before, flush after. Tell me about your IV. All right, I'm going to prefer a central line IV. Can a central line infiltrate? It cannot. Central line cannot infiltrate. The only way a central line can infiltrate is if your patient pulls it and gets it out of place. But those suckers are usually stitched in. If it's a central line, it's not going to infiltrate because it's in the superior vena cava or in the inferior vena cava. So that's why I say a central line and a midline are two different things. A midline can infiltrate. Central line cannot. All right, so I prefer a central line. So if my patient is on a vesicant and we don't have a central line, I'm gonna make the recommendation. I'm gonna make a phone call or I'm gonna put in the order. Hey, I want a central line. I need a PICC line. I need a central line. Whatever. All right, let's say I'm putting in that recommendation, but what kind of peripheral IV do I want to use if that's all I have right now? 18. I want a big IV. Where do I want it at? Yeah, I want it in these bigger veins closer to the heart. So like my AC, we all love those. So your patient can do this and ruin it for me. But the main thing is, do I want a 24 gauge that's in that little thumb IV right there? No, I'm going to rot their thumb off. So I won't. You ever seen that? I want a good big 18 gauge, preferably up here in these bigger veins. I don't want them little 24s and the pinkies, stuff like that. So good big IV, push it slow, dilute it out. Am I going to let it run by gravity? If I've got to put it on, like in a bag to give it, I want it on a pump. And if I'm going to push it, I want to push it really, really slow. Hopefully I got blood return on my IV before I start giving it. But we don't always get that. So good IV access. So that's my vesicant talk. I'm not going to go over it again. I'm just going to say, hey, here's your vesicant. You're going to have a test question every single test on a vesicant. So we've got chemo for immune. We've got our vasopressors for medical emergencies. We've got a couple more for perfusion. Basically, any electrolyte is a vesicant. So you got to be real careful with that. All right. Airway precautions. Yep. Calcium lab checks. We already did my DTR talk.
knows. Diuretics, do those help drop phosphorus levels?
No.
They don't. See, MRI, so we're looking for that for, my bones, along with fall precautions, weight bearing, grippy socks for my fall precautions, OT, yes. Diet nutrition, yep. I'll take that off. Yep, we'll leave that. Okay, dialysis, I'm putting down here again, last resort. While weight bearing exercises. Yeah, helps build up stronger bones. Okay, how do you feel about those? Feel good? Yep. Okay, cool. Earlier, how long do you give all of our interventions to work until you move to dialysis? So the answer is however your patient is doing. If your patient is stable and tolerating all the work that we're doing, we're gonna keep on keeping on. But if your patient ever becomes in danger, or we see that they're headed towards danger, then we're gonna have to move towards dialysis. So I'm gonna give you like a quick rundown on how dialysis actually works. Okay? So in order to do dialysis, we have our little patient here, a little happy smiley face. I guess I should, like, if we're having to have dialysis, we probably need a frowny face, because we need dialysis. Alright, so first off, we're gonna have to have some type of access. So if you look on Canvas, there is a worksheet that has several different types of accesses, and it's got a sign that says pros, cons, and what type of dialysis can you use. So those are things I want you to look up and then come back next week so we can talk about the pros and the cons. So I need some type of access. And there's about 5 different kinds that I've listed on. So we'll go over there next week. So I'm gonna get some type of access. And so we're gonna talk about hemodialysis because this is what 90% of patients do, is hemodialysis. There's another kind we'll talk about next week, it's peritoneal dialysis. Literally less than 10% of patients can do it. They either don't tolerate it or it doesn't work good enough. So we gotta do hemo. So we're gonna do some type of IV access, and we're gonna pull blood out of the patient and put it into our dialyzer. Lord help me, Jesus. Which is part of our dialysis machine. So I put my dialysis machine over here. I'm gonna say dialysis. It'll make sense in a minute, I promise. So we're gonna pull blood out of our patient, put it in our dialyzer. Our dialyzer has hundreds of semi-permeable membranes in it. That's what this little dotted line represents, a semi-permeable membrane. The blood's gonna go through one side of the semi-permeable membrane, and then go back to the patient, and then circulate again through that dialyzer with the semi-permeable membrane. Now what's on the other side of the semi-permeable membrane? Dialysate. So this is where we use our dialysate fluid, and it is gonna go up the other side of the semi-permeable membrane one time, and then go to the toilet, or a drain, or somewhere else. So on this semi-permeable membrane, we got blood going through one side, we got dialysate going through the other side in opposite directions. Now what does a semi-permeable membrane want on each side? It wants it equal. It wants everything equal on both sides. So using osmosis and diffusion, so higher levels of concentration are going to go to lower levels of concentration so that we're equal on both sides. So we're going to use the example of potassium because that's what we were just talking about over here. So potassium, let's say my patient's potassium level, we've done everything we can, and their potassium level, we're going to make it real bad. We're going to say it's 8. Ooh. Yep. Ooh. Because what's your normal potassium level? 3.5 to 5 or 5.5 depending on your lab. electrolytes in it. It's gonna have calcium, it's gonna have phosphorus, it's gonna have bicarb, it's gonna have all of your electrolytes in it, and it's all going to be normal levels, okay? So when this blood comes out of the patient with its potassium of 8, when it comes out, what's potassium gonna do?
Go to the other side.
It's gonna cross over and go with the dialysate to the toilet. And then we go back. And now when my blood goes back to my patient, what's my potassium?
Oh.
And then we do it again.
Oh.
And then we do it again. And we keep doing it until, all right, now, when it finally hits this, what happens? Yep. All this stops. Because now potassium is equal on both sides of the semi-permeable membrane. We have to have normal levels of potassium over here, because if I made it too low, what am I going to do? I'm going to drop my patient's potassium level too low. So I have normal levels of my electrolytes over here. The cool thing is, this works both directions. So what if my patient's calcium level is low, but I have normal levels of calcium in my dialysate? What's going to happen to the calcium? It's going to go over here, because it wants everything equal on both sides. So that's how dialysis works. Does that make sense?
Yeah.
All right. So with this, dialysis usually is going to run for 3 to 4 hours, because that's how long it takes for me to circulate the blood through this machine enough times to actually get this to equalize out. This is going to run at 400 milliliters per minute. Thank you. Whoa. Because y'all are used to milliliters per hour. I got show and tell. Hang on. This is why I showed you your picture on your clinical orientation. This is a normal central line. See how skinny it